Dr. Wu, thank you very much. Okay, this is great that we have a small format so that really if you can all ask questions, what we want to be able to answer as much questions as we have. Sometimes we will not be able to answer the question and we will say, I do not know. But what we'd like to do today is give you a framework of how we would like you to look at the information that we're going to be presenting during the course of this seminar. And I hope that you can use this information in this framework also to look critically at the literature that we are reviewing. There is so much literature coming out, and it's impossible to absorb the amount of information that's coming out in our different areas, and specifically in neonatology. And so I'm going to talk a little bit about that and about our experience doing clinical trials and what we've learned by trial and error and trying to understand and determine if evidence is good evidence or if it's not good evidence. It's very important. We tend to think that just by us being neonatologists and practicing neonatology, we learn this. But it's not like that. We really need to study this and make it part of our long life commitments, both of studying disease and studying in neonatology. Will also, evidence-based medicine is a whole learning process that has to continue because it's changing very rapidly. So the first word that I just wanted to start here was beware of the word standard of care. What does standard of care mean? And for some people, it could be something that they've been doing for 30 years. But for other people, it might be interventions that they have in the NICU, that they exist because there's evidence to support the use of that intervention. And so what you want to be able to identify is if it's good quality of evidence or if the quality of that evidence is not so good. So yes, you have to be careful also with the word opinion versus evidence. Many of our professors in the past would give information, and sometimes the information sounded a little bit like dogma, and you did not question that information as it was given to you, and you reproduced that information. But we never dared to ask our professors, is this an opinion or is this evidence-based? Because I think there's a big difference between those two. Opinion is very important because it's based on experience, and experience helps generate hypotheses. But it's not evidence. And so they're very, very different. And so it's very important for us to take that into account when we receive information. George Bernard Shaw, a long time ago, wrote these words: doctors draw disastrous conclusions from their clinical experience because they have no conception of scientific method and believe, like a rustic, that the handling of evidence needs no expertness. This, a long, long time ago, is still today very, very important because, again, we have so much information coming out, and we many times take that information, but we don't really look at it critically to decide what the quality of that evidence is. And to be able to critique that, of course, you need to understand the scientific method. Nobody wants neonatologists to become statisticians. That's not the goal. But to understand the evidence and how it's been developed to be able to determine quality is very important. So the objective of all, and what we're trying to do with our residents and with our fellows in training, is to try to develop and work with them to develop an inquisitive mind so that they question us. In the past, many were afraid to question us, but now when we go on rounds, we say, you have to question us and you have to ask us when we state something if we have evidence to support that. And so we're used to now saying, okay, I'm going to give you an opinion about what I think is the best way to treat this specific neonate with this specific problem. But this is an opinion and it's based on my experience, and I do not have any evidence to support that. It's a disclosure that you give to the students and to the residents and the fellows so that they know clearly what you're talking about, and so they don't get confused between what's evidence and opinion. And so this very famous painting. So this is the type of personality that we're trying to get our students and our residents to have that inquisitive mind. They have to put their finger in the wound and demonstrate, yes, is this really true objective evidence, yes, and not just take it by faith. It's very important that we develop this. And I believe Thomas was a very inquisitive individual. And I think that's something that we should take into account. And also, you recognize Socrates always asking why. Not always being politically correct, but important in medicine, asking why. Why are we doing this? Many times we look at our practices, and I'll give you an example, and for many years we repeat the same thing, the same interventions, but we never ask ourselves, why are we doing this? And is it correct to do this or to use this specific treatment? This is a word that I think is very important for all of us to know, but I don't have a very good interpretation or translation of this word. I speak Spanish, that's my native language, and we don't have an exact word for equipoise. So when I talk to my colleagues in Colombia, I give them an example. So you have treatment A and treatment B. And in one hospital, they say the best treatment, or I'll give you an example, respiratory distress, is this treatment A. In another hospital, they say, no, it's treatment B. That's the way we've done this for a very long time, and our experience tells us that this is the best treatment. And then you say, okay, we need to do a randomized control trial to be able to determine if treatment A is better than B or treatment B better than A. And then historically what has happened is that the doctors from this hospital say, well, we can't participate in your trial because we feel that we can't submit our patients to something that we believe is inferior to what we're doing here. And then you go to the group in this hospital and we say, we also can't participate in your trial because we feel that our treatment is better than this treatment. And so this is what we would call lack of equipoise. Why would we call this? So if we got these investigators to sit down, these doctors from these hospitals, and we ask them, review the literature on these two treatments and look at the evidence objectively. And if after looking at the evidence objectively, you find that, yes, there's good information that treatment A is better than treatment B, perfect. You lose equipoise because now you have evidence that this is better than this. But at the same time, when you review the literature, you might find that when you look at this treatment, they can't say that this treatment is better than this or this treatment is better than B. And that's what happens the majority of the time. When they look at the evidence, what's written in the literature, what's been studied, they can't tell between treatment A or B. And if I can't tell which is better than treatment A or treatment B, that means that I'm ready to participate in a randomized controlled trial. And that means that I've acquired equipoise, and then I feel comfortable participating in it. But why do many of the important trials in neonatology have been stunted, have not been done? And we'll have many examples of these as we go through all these presentations. They've not been done because people have lost equipoise, yes, without objective evidence, just based on opinion and experience. That's why it's so important for us to check ourselves and ask our questions with respect to treatments that we go in the unit on rounds and we say, this is the way you have to do this, this is the way you have to do this. You have to question yourself, do I have equipoise here? Am I saying this because I have objective evidence or I'm using my experience and my opinion? So again, experience is not bad. Experience is very, very important, but let's break down the concept of experience. So let me give you an example. This is congenital diaphragmatic hernia, and they looked at their data in the state of California. The California Birth Defects Monitoring Program reviewed 237 cases of congenital diaphragmatic hernia from over 700,000 births to provide insight based on California's experience. Statewide, this was the incidence. 3.3 per 10,000 babies were born with diaphragmatic hernia, about 200 babies each year. They found that 55% of those 110, of live-born babies with isolated diaphragmatic hernia were alive at age 1 year. But only 29% of those with additional birth defects survived. None of the 15 with chromosome defects lived. 10 cases were stillborn. All had multiple birth defects. So we have an ECMO referral center in California, anyone. There could be 150. We'll take one of them. And they say they see approximately six cases per year. That means in that institution they see 3% of all the cases of CDH in the state of California. And there's a neonatologist in a group of 5, 10 neonatologists that work in this unit. They have an ECMO program there. They see, each one sees around, if they're lucky, 2 cases per year. So that's only 1% of the 200 cases. Yes, if he works, that neonatologist, for 30 years, he's going to see 60 babies with congenital diaphragmatic hernia out of 6,000. Continue to see only 1%. So his experience is only based on that small percentage. And so if I come and say, well, I'm the world's expert in congenital diaphragmatic hernia, that's not very humble when you look at this information. And that's just in one state of California. If you add all the states of the United States, just in the United States, how many babies are born with diaphragmatic hernias? We will see only a little tiny part of those cases. Their survival rate, and you read papers from universities where they say our survival rate for babies with ECMO is 80%, when the national is 55%. And you say, wow, they must be doing something better in their hospital than what happens nationally. Because if nationally we're doing 55% survival and they're doing, they're 80%. And many times you read the papers and they present protocols on how to take care of the babies, gentle ventilation, hypercapnia, different things. But they look at that and they say, this is the way it should be done everywhere else. And you look at your institution and maybe you don't have 80%, but you have 75% survival. But it still doesn't match that 55% that is what you see nationally. So one of the problems is, what is the denominator for your 80% survival? You have to look in detail at the denominator. And that's what we did with one of those papers that came out. We looked at their true denominator. So what happened here is that the number of CDH cases managed per year divided by prenatal non-survivors plus postnatal cases of CDH. That's how you would like to be able to look at that. And so in the prenatal non-survivors, you have cases that are diagnosed prenatally and that never survive because they are aborted. And many of these cases, they have associated congenital anomalies that are poor prognostic cases, but they are aborted, so they don't appear in your denominator. Then you have postnatal cases of CDH. And so you can divide them in outborn and inborn babies. If you include outborn babies who died prior to transport, that would be part of your denominator. But that doesn't go into the denominator that we include when we talk about diaphragmatic hernia. We've had cases where we sent our transport team to pick up the baby, but the baby doesn't make it through the transport and the baby dies. They have the severest forms of congenital diaphragmatic hernia. You have outborn babies who survived to transport into ECMO, inborns who died prior to ECMO, inborns who survived to ECMO. And then you have a group of babies that are survivors without ECMO. Babies that are born, they're on the ventilator, they have mild pulmonary hypertension, never go to ECMO. So when you look at ECMO survival papers, they usually only include inborn babies or outborns who survived to transport. So you selected the group of the best survivors with congenital diaphragmatic hernia as your denominator. And so your data looks much better than the reality. You're getting a very select. That's selection bias in the way you interpret your data. And so you might look and say, well, it's not only the protocol that's creating this 80% survival in your institution, but it's the way you're looking at the information. So the general objective of evidence-based medicine is to stimulate your interest in methodological inquiry. And here is, I found this from 1753. It seemed to be the first ever randomized controlled trial that has. And it's written just the way you see it over here. So I took 12 patients in the scurvy on board the Salisbury at sea. The cases were as similar as I could have to them. They lay together in one place and had one diet common to them all. 2 of these were ordered a quart of cider a day, aside from their diets, what they were eating. 2 others took 25 guts of elixir vitriol. 2 others took 2 spoonfuls of vinegar. 2 were put under a course of seawater. And 2 others had each 2 oranges and 1 lemon given them each day. So you can, and the other ones had nutmeg. So you can, this person who thought this out was fantastic. And he was the first one to diagnose the treatment for scurvy. And he did it with just his methodological inquiry. He already had it in his mind, and so he selected the groups and they gave distinct treatments, and then he found out that this group of oranges, those did not develop the disease. But that's the type of thought process that we want everybody to have. It starts by things that are very, very simple. You think that research has to be very, very complicated, but some of our greatest discoveries were done by minds thinking in this very simple way, but very organized. So I'm going to go over some very quick things in neonatology that, and in general in pediatrics, where there was conflict when the questions were asked of why do we do this. Does anybody know what a Kenny pack is? No? Nobody have ever heard of this? I hadn't heard of it either. But Kenny packs, we're going back to the 1930s, 1940s, polio epidemic. And so very important hospital, and if I'm not mistaken, it was the Columbia Presbyterian, but I could be mistaken there. There was a sister, a nun, her name is Sister Kenny. And she had developed a treatment for polio, children with polio. And they were these warm packs of water that they would put around the legs. And she was convinced that that made these patients well. And everybody used it as a standard of care, and they used it for many years as a standard of care. Then one day, one doctor came in and he said, "Show me the proof that this works." And everybody said, "You cannot question Sister Kenny. Be careful, you can't say that. If you say this in this hospital, you will not survive here. You'll have to leave." And the fact that it created a tremendous amount of conflict to the extent that this person was called upon and signaled because of questioning the Kenny packs. And then later on, somebody decided to do a study comparing those that didn't get it and did get it, and they found out that Kenny packs did not do anything at all for polio. But this was a belief that all physicians, everybody was practicing and was doing with faith. Oxygen, we'll learn a lot about oxygen during this. You know, we never even understood it. We never thought it was a medication, and what we breathe is a medication, and if you get too much of it, you can get sick from it. Well, only 5 years ago, we were giving babies that were 23 weekers, 24 weekers, 100% oxygen during resuscitation. And today, we'll talk about the consequences of that and why we're trying to change. Mechanical ventilation, very important for survival. It was fundamental to what we were doing, but we now learn about ventilator-induced lung injury. Chloramphenicol, we used it. Did anybody ever see a baby with baby Gray syndrome? Baby dying in shock, and and it was a fantastic antibiotic used in women with sepsis after birth, complications, but they tried to use it in babies, and they had this gray baby syndrome. Sulfas, we'll hear about the person who discovered that also, kernicterus from the use of sulfas. Recently, we had a trial with looking at 2 different levels of oxygen saturation limits, and we found out that one of those increased mortality. And so every day we're challenged with these same situations. Isolates, wonderful. We had isolates in the past that were used where water was accumulated in the isolate, and then a lot of babies were dying from pseudomonas sepsis from the isolates. And we didn't know that, and we blamed it on the environment in the NICU until we found out it was the isolate where these pseudomonas were coming from. H2 blockers, very interesting experience. A couple of years ago, I tried to do a trial with H2 blockers. We did a multi-center prospective cohort study of nosocomial infection in the network where I worked, and we found out that the risk factor that was most highly associated with nosocomial infection was the use of H2 blockers. And so we went and looked at what happened. Why do we in neonatology use H2 blockers? And I started to ask that question and found out that nobody knew. He said, well, the pediatric residents, if you go to the pediatric intensive care unit, every single baby that gets in there, because they're in trauma, the majority of trauma patients, they all get immediately put the H2 blocker within the TPN. And so what happened was that the residents started to take that practice and they brought it into the NICU without us ever even implementing it. And then it was just part of the routine, part of the standard of care. And everybody was putting it in there. And then only with time, another study that came out of Yale, another multi-center study showed that H2 blockers was also associated with a higher risk of nosocomial infection. And we know that decreasing the acidity, that babies, preterm babies, can bring their acidity down to 3, but if you give an H2 blocker, you make their pH in their stomach 8, 7, and that increases bacterial translocation in the gastrointestinal tract with gram-negative bacteria. And of course, you can induce more nosocomial infection in those patients. The steroids, we've heard a lot about what they're put from a neurodevelopmental perspective. The use of hydrocortisone for hypotension, a good idea, but as always, there was something that was negative about it, bowel perforations, and this is just another example of cephalosporins. So this is Dr. William Silverman. He's the researcher that was very important to determine that study that looked at sulfus and kernicterus, but also was very important showing that survival of babies at certain temperatures in isolates were higher than those that did not have, those that had temperatures that were lower, very important for that. And he wrote a book on evidence-based medicine, and his quote, very important quote, that everything, absolutely everything that we do is a double-edged sword. And we don't explain that to the parents clearly. And they think of treatments as something that heals, but we don't give them the other side of the double-edged sword. Everything cuts on both sides, but what we do in medicine is accept where it cuts less, but it doesn't mean that it's not cutting it. It cuts on both sides. Furosemide, wonderful diuretic, necessary for the use of babies who have chronic lung disease, but at the same time, it's going to produce osteopenia and you can have fractures. But we give it, and we never explain to the parents until, oh, there's a fracture, and you go and tell them, oh, there's a fracture here, it's from the medication that we're giving your baby. And they said, you never told me that. Well, we're not used to telling the double effect of what oxygen does, what mechanical ventilation does, what H2 blockers, that we just start these medications. So it's very important. This is a very fundamental concept of what we need to put into practice. A more historical background. First clinical trial with a properly randomized control group was the streptomycin in treatment of pulmonary tuberculosis. We'll see that in neonatology. Does anybody remember what's the first randomized control trial, what it looked at in neonatology? I like to bring these because its history is very important. Understanding what they did in the past and how we get here was very important. Does anybody remember? Okay, we'll talk about that, but that's the ROP, the first ROP trial, and we'll talk about that. But in neonatology, that seems to be. Wikipedia, anybody know who that is? Not a good place to find definitions, and I would not recommend it, but this definition caught my attention, and that's why I put it here. And it says, evidence-based medicine or evidence-based practice aims to apply the best available evidence gained from the scientific method to clinical decision-making. It seeks to assess the strength of evidence of the risks and benefits of treatment. So it's looking at the double-edged sword, including lack of treatment and diagnostic tests. Lack of treatment is very important. A lot of things that we look at, that we use, they are expensive. We need to rationalize our resources. So if there's something that doesn't really work very well, like the Kenny packs, just an example, that should disappear from our practice. But I felt that this definition is comprehensive and it's easy to understand. And so what we need to do is be able to classify the levels of evidence. And so I'm going to give you two classifications, one that's used in the U.S. and the other in the United Kingdom. But these classifications are changing because now we're looking at different ways to analyze data. Yes, the analysis of data is also changing. Everything changes, of course, and we have to be on top of what's what's occurring, because we're going to get that literature, and if we don't understand the concept, the general concept of how they do these things, we just don't question. We don't ask why, or we just accept it, and I'll give you some examples of that. So you can see very clearly at the top you have evidence, you have the randomized control trial as the gold standard. Well, today we know that that's not sufficient. It's nice to have a randomized control trial. But for all of us who have been involved in randomized control trials, we know very clearly that there are different levels of quality of randomized control trials. You probably could subdivide them into 4 categories, from the best to the worst, but there's a whole classification within randomized control trials. So if somebody says, no, this is the best evidence because this is the randomized control trial. Yes, what is the quality of that randomized control trial? And you have to question that. On top of that, now you've heard of all systematic reviews and meta-analysis. Well, in the same way, you have to now look at that and say, well, there are different qualities of these systematic reviews and also of meta-analyses. We've had a lot of conflicts in papers that have been done with meta-analysis, which come with some conclusions, and then another meta-analysis comes and says the opposite that the first meta-analysis was saying. So that's something that we have to learn. And you can see all the different levels, and I'm not going to go through them, but you can see where our level 3 opinions of respected authorities based on clinical experience, descriptive studies, or reports of expert committees. And again, it's not that I'm putting that experience down. I think it's very valuable, but we have to humbly say that even if we lived 100 years, the experience that we have to be able to talk, you know, what part of the denominator is our experience? And it's a very, very small part. But it's very important to generate hypotheses and then to generate, of course, studies. So the experience is very important. This is the system that's used in UK, National Health System. And again, at the top, you see randomized controlled clinical trials, cohort studies. And then you have in the level B, case control studies, you know, and level C, case series. And then you have level D, expert opinion. And this is something that they put there so that you talk to the families about the intervention that you're using. You know, and just go at the top, you say, if it's level A, good scientific evidence suggests that the benefits of the clinical service substantially outweigh the potential risks, which is what the parent needs to hear. But they, of course, and they'll say, well, what are the risks? And the risks are these and these and this. But we, you know, this is what we have at the present time. We don't have a better treatment. And level C, at least fair scientific evidence. And then they have a level D, at least fair scientific evidence suggests that the risk of the clinical service outweighs potential benefits. And then the level E, scientific evidence is lacking, of poor quality or conflicting. And you would be amazed if we look at everything that we do in our neonatal intensive care, how much of that falls into this category. And we all know it, and we all know it. But of course, should be a stimulus to then say, okay, we need to work more to try to find good information or to produce that information that's going to make this a level A instead of a level E. And I mentioned the systematic reviews, the Cochrane, very important, and I think they're also in the process of change. They're reevaluating the way they do their meta-analyses because of a lot of the conflicts that have gone around that. And so, again, they're evolving, but of course, this puts together the information and helps you to look at it, but you have to go beyond what's presented there. There is multiple meta-analyses that have come out with probiotics, for example, and there was one where they said, well, now after doing this meta-analysis, everybody should stop doing their randomized control trials. It's not really ethical to continue because we're showing here that this absolutely demonstrates that we decrease necrotizing enterocolitis. And the problem with that is that the group where I work we were in the middle of a study that was a probiotic study. And that really hurt us because people didn't want to randomize patients into our study. And so we went back and we contracted a company that looked at that meta-analysis. And they called it a great analysis to look at the quality. And they looked individually at all the studies that were included into that meta-analysis. And there were multiple studies that didn't even have NEC as a primary outcome. They didn't even have a definition. They were looking at the biome of the gut and colonization and other factors. And they included all these trials in that meta-analysis. and not even neck being part of that primary outcome. And so back and forth, the important thing is it's like a computer. If you put good information, good quality information from the computer, you get good quality results. If you put bad information or regular information, you get bad or regular results. Well, with meta-analysis, you have to be very careful because it's the same thing. Whatever you put in it, you can't get great results with poor data. It's just not possible to do. So the other thing is, and this goes for us also, we tend to bow to what certain journals with a certain prestige put into their journals and articles and accept them because they come from the New England Journal of Medicine or because they come from JAMA or because they come from pediatrics. It's very important for us to understand that we have to always take with a grain of salt the information that is presented. It doesn't matter what journal it's produced. The best journals in the world have made mistakes. And we'll talk about that and looking at short-term outcomes and long-term outcomes. So this is very important that you understand this. Stuart Packard is a very important biostatistician, and I think I agree totally with what he says there. I think many of us agree with that. Because we have to understand the peer review process. The peer review process is you don't have the opportunity or the luxury to selecting the people that are trained to look objectively at the evidence and to understand it and critique it. It's a voluntary process, and so you do not have very much control. If you submit your paper, it is possible that you might get somebody that has that expertise, but it's possible you might get somebody who doesn't have that expertise, but has an opinion because has participated in a study similar to what you are presenting to that journal. And your paper might be a good paper and it be shut down and not accepted, and you think that it was because it was a bad paper. And some papers did not show a difference, and so many of those papers were rejected by the journals because they wanted papers that showed a change, an impact. And if your paper didn't do that, then you were taken out. It's like making your denominator shorter and shorter and shorter. And so there is a whole culture that needs to be changed around that. But the peer review process is something that's important, but it also has to be looked at with a grain of salt. So conflict of interest, that happens a lot. We should talk about that. Many times they ask you when you submit your journals, is there anybody that you would not want to submit your journal to? And it's sort of for the bench researcher and for the investigators that are concerned that somebody they're competing and trying to produce information, you don't have that other person look at your study and then reject your study because it's human. It can happen. It does happen. We've seen it happen a lot in bench research. So they have to be very careful where their information goes. When it's very specialized research, of course, there's only a couple that might understand what you're doing, and that's where there is conflicts of interest. And so the person who receives the paper should look at it and says, I have a conflict of interest here because my opinion is absolutely different from this person. And it could be opinion, and it's not evidence-based. And so it's better to say, I can't review this paper and send it to another reviewer. Can we differentiate between what is good evidence and what is bad evidence? I think that that's something that we can do. So this is something that we tell our residents and fellows when they look at the literatures. You can't read all these papers. That's a reality. So we need to rationalize it. And so I'm just going to go through what we work with them to have them incorporate into their natural way of looking at these articles. So we tell them the first thing you want to look at is the last paragraph of the introduction of a manuscript. And in the last paragraph, they have to have the aim of that study. They have to have the main question that they're asking in that study. And so after that, we tell them, you go now to the discussion. And you look at the first paragraph of the discussion. And you should find the answer to that question in the first paragraph of the discussion. If you don't find the answer to that question in that first paragraph, you have to be very, very careful, because that's what you would expect that they do, that they answer that question there. If they did answer that question, yes, and they did it appropriately, then you want to then go to the methods section and read the methods section in detail, because that methods section has to be as clear as possible, because the objective of the methods section is that anybody can take that paper and reproduce it. Many years ago, I would read these methods sections and I would say, oh my gosh, I'm really really, really dumb. I don't understand anything that they're saying in the methods section. And I would reread it and try to understand it, and never understood it. After many years after that, they told me, if you can't understand it, it's because it's a problem in the study, and it's not your problem. It should be easy for the reader to be able to understand the methods. If you can't, then, you know, of course there are some areas of expertise in research that you just don't know all the methodologies that they use for very complex research. But in general, in clinical trials, in clinical studies, the methodology should be very easy to read and to reproduce. So if you understand that, then everything's great. Then you go look at the results in the tables and see if they correlate well. And then at the end, you go to the discussion. And instead of reading the discussion, you look for limitations. And if you don't find a limitation section, then you become very, very concerned. For all of us that have participated in randomized controlled trials, we know, honestly, every single study has limitations. Nothing comes out perfect like you plan it, and you have to be honest and disclose that. And if you don't disclose your limitations, then you should be concerned about the quality of the paper. So many times you might not get past the first and the second part of it. If you don't find the answer to the question that they made in the introduction, it's not worth continuing with the paper. Reading an abstract, not at all. That's a tiny summary, and it has an objective of creating some impact so people will come and read your paper. But don't ever use abstracts to make conclusions from abstracts. And we tend to do that, and it's not our fault. It's because we have a lot of work and little time, and so we look at the abstracts and we think, oh, I like this, I don't like this, and then it stays in your head, and then you reproduce that information. You want to at least get the paper and go through these, and then if you're able to go through this and you practice this, you'll be able to quickly discern which are good papers and which are not. John took you another biostatistician, the most very important person, the most important maximum for data analysis, and which statisticians have shunned is this: far better an approximate answer to the right question, which is often vague, than an exact answer to the wrong question, which can always be precise. So when you sit down with our residents and fellows and you say, okay, let's formulate questions for research, and this is really hard, making a good question, and making a simple question. And what I've seen is that when somebody has that capacity to make it very simple, a good question, and then you have a way to measure and that is simple, and then it becomes more likely that you're able to do that study. When you have a question that is not clear and you just try to look at ways to then measure an outcome from a question that's not clear, it's a big problem. So I think it's part of an art that you can then look at something, observe. We're in our society, we work very, very hard, but we lose that great capacity to observe. And if Einstein were here at this point in time, he would suffer in our academic systems because everything moves so fast. And you have to be working, and you have to be reading, and you have to be teaching, and you have to be producing research, writing grants. And it's very difficult to just stop and observe what's happening to our patients, and come up with very simple questions. And I think that that's one advantage that he had when he was able to not be within the academic environment and have the time to think clearly and the thought process and start with simple questions that might seem very dumb, but those were the best way to start all his thought experiments. And again, this just goes over the methods that we talked about when we go to the methods section. It is the design of a clinical trial which largely determines whether an unbiased or objective therapeutic comparison can be made. In general, one should not give the authors the benefit of the doubt and one's suspicion, and should remain until provided otherwise. It's the Thomas issue. You don't give anybody the benefit. You want to look at the information. And if it's a good study, you say, yes, this is the reason why this is a very, very good study. Can I change my standard of care based on this information? Maybe, maybe not. But what do you have in comparison to that information? You might not have anything at all. And so your best available evidence is what you have. But you might not feel compelled until there's another study that reproduces something similar to that. Even if the methods section is flawless, there is still potential for distorting the results. Common deficiencies in results are all the ones that are enumerated there: too few patients, failure to account for all patients. An example, we did a randomized control many years ago on skin-to-skin care in the neonatal intensive care unit. And it was randomizing babies to one way of holding that didn't permit skin-to-skin care, and another to the skin-to-skin care. Babies could be on ventilators or on CPAP for this study. And it was very interesting that we thought that this was going to be an easy study, because we said, oh, mothers are going to like this. This is going to be a good study. We'll be able to randomize all these mothers into the study. It took 5 years to complete that study. It was the most painful study I've ever been involved in. Yes. Give me ventilators. Give me something there. Skin-to-skin care was terrible. They told us that one group said, oh, that's immoral not to expose babies and their mothers to skin care. And we said, well, where's the evidence? Show me the evidence. There was no evidence, no randomized control trials. And then the other group says, no, yes, you have to do this. But what we saw is that when we randomized, we expected almost 85% recruitment of mothers and fathers. We only got like 45% recruitment. They didn't want to participate in this study. And so what happened with the other 55%? They were not part of our analysis. We had to disclose that 55%, and they asked us, why did 55%? I do not know. We don't know why 55%. And of course, we didn't collect information on that 55% to try to find out why they didn't want to participate in this trial. So you've already created a biased population for your study, because you got the families that were more motivated. And of course, their development might look much different than the ones that were maybe needed it the most, which were the 55% that didn't participate in the study. So that's something that we have to do. Here you have other issues like inappropriate statistical methods, confusing presentation of results, data dredging. Data dredging means that you want to find a result. And so you start analyzing and analyzing and analyzing and analyzing until something comes up that shows a difference, and then you present it there. And so, yes, we would like to be able to find good results, but if you don't, you have to accept that you don't have a difference. And you have to present, we did not find a difference. That's the reality. We didn't have. Why you didn't find a difference, that's a different question. We can ask that question, why is it? And you can come up with also hypotheses and speculations of why it wasn't different. But data dredging is something that could be concerning. If the methods section are unsatisfactory, that's where he says you stop here. If your methods section is don't even finish reading the paper, because you're not going to understand what their conclusions and how they came to their conclusions. And I mentioned the limitations of our study design. It's very important that we do have a section where saying these are our limitations. This is where we had faults. This is what we couldn't recruit 100% or 80% of the population. All the mistakes that occurred in randomized control trials. We gave the wrong treatment to the wrong patient. That happens in all these trials. You have to say that you did. How did you analyze that patient? Did you include them in the same group, or did you take them out of the study? Sometimes they take them out of the studies when they should be included as intention to treat and keep them within the studies. And do they look the same here? Does this look the same? Okay. So they might look the same, but they're not the same, right? And so we've had discussions with our colleagues with respect to studies. So now we're going to compare. Let's say let's take CPAP, and you have 10 studies with CPAP. And so you have people sitting together to discuss about these studies, and this is better than this, and this is better than this. But when you want to really do comparisons, you have to be very careful and ask questions. Are you comparing apples to oranges? And the only way you can say, no, you're comparing apples to apples, even within the concept of probiotics or CPAP or types of ventilation, is whether the methodologies are the same. If the methodologies are the same, you're comparing apples to apples or oranges to oranges. But if your methodology is different, then you can't compare them. And you have to, that's why you need to understand the methods, because there's no way you can say, compare this study to that study, this is better than that study. You can't do that if you don't understand how they did the methods section. So you have 2 trials with inhaled nitric oxide in premature babies. Look at the methods and how they were done. And then you would be able to say, oh yes, they are comparing the same population of patients with the same intervention at the same time. But I can't compare an intervention that's given prophylactically to an intervention that's given second week of life and say that they're the same studies. I can't put them within the same group. They're different studies. And so it's very important to compare always oranges to apples. How are we doing with our time? How much time do I have left? Okay, no, I don't have that much to say. Okay. So this is another problem when you look at and you read the studies. So that you have the one-tailed study, and it says this is a one-tailed study. When you do a one-tailed study, you're basically telling everybody that you already believe that this intervention doesn't have side effects, and that you are going to demonstrate only efficacy. And this is a very dangerous study analysis. And I'll give you one example, and it occurred in 1995. And I'll give you it's a medication that was used to lower blood pressure. And this medication showed that if you gave the patient this blood pressure, you were able to decrease systolic pressures by 20%. And they repeatedly showed that, and it was very consistent. And so the FDA said, good, we approve this medication. 6 months after it came out and it was being sold, 4 patients were dying with hepatic failure. And what happened is that they did only the efficacy for a short-term outcome. They didn't do their long-term outcome. And they did not know that their patients were going to die from hepatic failure because this medication was toxic to the liver. And so this even occurs with a whole very strict system for controlling medications. So when you look at these papers, yes, you have to disclose that you're looking at a short-term outcome. It's much more complex when you have to do long-term outcomes. There are studies that are much more expensive. They take much more time, labor-intensive. But those studies really are the strongest studies because you can see what you should be seeing, which is looking not only at the benefit side, yes, and if it falls around here and you find efficacy, wonderful. But if you, whatever you find of value in this Gaussian curve of probabilities falls on this side, then you're finding out first that there's negative effects that can hurt your patient with that medication. And so this is fundamental. And I can tell you how complicated this is, that at the time when they were doing the HIV medications, this was a big issue. And so at that time, the investigators who were doing these, and I met one of these at Yale, he said, you know, they're hurting us because they're asking us to give this medication outside of our trial for compassionate care. And if we do this, people will not want to participate in a study where they only have 50% probability of participating in this trial. And they were very concerned because it was the first time they were using these medications, AZT. And what happened there is that they started a randomized controlled trial and they never finished the randomized controlled trial because everybody started to use it outside of the trial. And so their concern was, and they would say, we're shocked that this has happened because we don't know what this is going to produce. Now, again, if you believe in that concept of the double-edged sword, you will be clear that everything that we do needs to have 2 arms to it. You have to be looking on both sides of the Gaussian curve. So it's not acceptable now to have studies that are one-tailed. There might be exceptions to the rules, but they're really true exceptions. But in medications, in certain medications, yes, the negative aspects of these could be so large that it's important to look at them, especially when you're using them in populations as vulnerable as our patients, which are very immature, premature infants. So the problem is that if you want to look at this outcome, the sample size for this outcome, efficacy, could be very manageable. If you want to look at efficacy and you design your trial to also answer the question, is it safe, then you will need a much larger sample size. And of course, you have to put more money into these trials and more time. But we tend to want to do short-term because we don't have to go through the complexity and the time that it takes to look at long-term outcomes. So very important to look at this issue of the 2 tails for this specific issue. So the way we always look at it, our mind always wants to look at efficacy. And so a safe way to look at this is to change and put efficacy as a secondary outcome and safety as the primary outcome. Because that's what we've all committed to doing when we take care of patients, to do no harm. That's supposed to be like the first thing, do no harm. So safety is fundamental, but again, that's not the way we think. We want to look at efficacy, and we want to find efficacy. Somebody told me, oh, well, if this issue about equipoise, is that important for a bench researcher who's in a lab? And I said, well, this is my opinion. But if you're a bench researcher and you have, the stakes are high, you have a grant, and you need to produce results, you're under pressure to find results. And so absolutely, you have to look at equipoise to the extent that you are very clear that if you do not find any results, it might even cost your grant, and your money is going to be cut. But you have to be very objective and maintain the equipoise and say, I did not see what I was expecting to see. But the whole system puts too much pressure on our researchers, to the extent that some feel a lot of difficulty saying, you know, I did not find any results, and this is a negative study. In safety issues, it's the same. They want to get that product out. They want to see a result, and then people will start seeing what's not there. That happens when you're looking at a microscope and you're trying to look and say, do I see a change here? Is it there? Is it not there? It can happen even to the bench researcher. So as clinicians in our clinical research, it can happen the same. So these are all the different studies. People tend to say, well, if it's not a randomized controlled trial, it's not a good study, because of all the confounding. I think that that's not fair for all these different methodologies. They've been very important to where we are and everything that we do. They've all participated in making the quality of what we do, taking care of patients. I think all these studies are very important. They're very specific for what you want to do. Obstetricians, for example, if they're looking at an outcome like twin transfusion, they won't ever be able to do even a multi-center trial because of the low incidence of that outcome. And so necessarily, yes, they have to use case control methods to be able to look at their interventions. If they're going to do laser ablation, they need to use a different methodology, because randomized controlled trials simply will not be possible to be done. And you'd like to say, well, why don't you do a randomized controlled trial, to see if laser ablation of the placenta really improves the outcome. And you can spend 10 years doing that trial, and it's been going on for a long time. I think there's still randomizing patients for a long time, but it's very, very complicated. But case control studies can be done. Prospective cohort studies are the closest thing to randomized control trials if they're done well. Being able to have babies that are born without the disease and following them over time and looking at the different variables that are associated. They have limitations. They're going to tell you about risk factors associated with this. Associations, not causation. Causation, your randomized control trials. But they're the ones that initiate that process. Very, very important. If we don't have case control studies, it's very difficult for us to move forward in doing good randomized control trials. This is it. And so these are some advantages that you already know on going over retrospective and prospective studies, and I've just mentioned some of these. And you can see here, of course, the smaller number of subjects in retrospective suitable for rare diseases. Disadvantages, of course, biased recall. Prospective studies, again, their advantages and their disadvantages. Expense is always a big issue, but I think that one of the things that we found out is that when you have colleagues working together from different hospitals and you come from different areas, we know that if we look at one unit, it's like looking at one individual and their experience. And the same is when we look at all the denominator of neonatal units, one unit is just a small fraction of that denominator of all NICUs. And so to be able to work collaboratively, to look at and answer questions prospectively, and if it's done appropriately with collaboration, that's the best way to do it. And I'll give you an example. When we first did our randomized control trial, we went to my country, where I'm from, Colombia, to do that. And we had neonatologists from different cities and from the same cities and all, but who had never talked to each other, who had never even communicated with each other. And each one of them said, this is the best way to do things. And the other one said, this is the best way to do this, and this is the best way to do it. And so we were very risky at that time. We did a randomized controlled trial of high-frequency ventilation versus conventional ventilation in a setting where there was no ECMO and there was no nitric oxide at that time. And we were looking at late-term and term infants with respiratory failure. And so it was a true randomized controlled trial. And so we sat all these people, like all of you who are here, we sat down to look at this protocol. And it was very interesting because it took like 4 hours discussing, and people on the other side thought that we were fighting amongst each other. And everybody was screaming, saying, this is not the way, this is. And it was very interesting because after 4 hours, everybody came out quiet out of the room. And they agreed to do one protocol. So it is always very possible to bring people together with one objective in a well-designed trial. That is the best way to answer questions now. And this is something that we really would like people to understand, that it's working in multidisciplinary studies with good designs. We can really do good randomized trials and answer questions. And technology is also facilitating this process. So I'm going to end very quickly with this because we've talked, we're talking about hypothesis testing, and what I'm going to try to give you is some examples. One of the big issues that we have is calculating sample sizes. And usually when you read papers, you don't do the calculation of the sample sizes to see if it was appropriately done. And that's something where you have to look at with a lot of care. We just finished doing this randomized control trial where we had 750 babies randomized to a probiotic and a placebo. And when we calculated our sample size for this study, the incidence of mortality and nosocomial infection in the hospitals that were going to participate, and this information was obtained from a prospective cohort study that was published in 2005. And that paper showed that there was a 28% incidence in babies less than, this study was less than 2,000 gram babies. And so we used that incidence to calculate our sample size. But our study took almost 3 years to finish. And when we looked at the interim analysis of the study, yes, we found out that in the control group, our placebo group, the incidence of that outcome was only 17%. We calculated our sample size on 28%, and it went down to 17. And immediately we became absolutely underpowered. And what that meant was that we had already 750, we needed 860 more babies to randomize to be able to be powered. And so that basically killed us because we didn't have the money to randomize 850 babies. We thought that 750 was too much, but many of these studies, they confuse you because they don't tell you why. And there's a simple way that, if you calculate the sample size and you say, my intervention can reduce that outcome by 50%, wow, that's a tremendous intervention. That's almost like the AZT study, the vertical study, that stopped at midterm because it showed efficacy in the interim analysis. Rarely do we have those trials in neonatology. So if you put 50%, then you need a very small sample size. We put in ours a difference of 30%, and we still were underpowered with that. And so one of the questions that we have to ask as clinicians, and that's where all of you as clinicians can participate, is what is realistic? And what would you as a neonatologist be happy with if you were able to decrease the incidence of an outcome? If you had chronic lung disease, let's say, can I ask you a question? If you wanted to decrease chronic lung disease, what's your incidence of chronic lung disease in your unit? Do you remember? Anybody have an example of what their incidence of chronic lung disease is? Let's say it's 30%. If I can tell you that you can decrease with this intervention your chronic lung disease by 20%, as a clinician, would you be happy about that, or that's not enough?
No, it's good.
You'd be very happy to be able to do that. So if I'm going to design a study and I do 50%, it's because I must have this extraordinary intervention that's going to decrease and make science work real quick, when in almost 50 years we've not been able to decrease the incidence of chronic lung disease. Well, that helps me a lot because I'm going to use a little small sample size, but will I be able to answer the question appropriately? If I choose to say 20%, then from the beginning of the design of my study, it was not, our study was designed for 1,055 babies at a probiotic trial. And we were trying to make an effort to get to the 1,055 and with 30%. And if we would have used 20%, more modest, maybe more realistic, yes, it would have said you need to 1,800 babies for that trial. And then you would have said, well, we can't do it because we don't have the money to do that. Or you might have said, okay, let's do it, and that's going to be our goal. But we didn't do that. We had our resources set for 1,055, and when it came, 1,800. So in trials, you have to be very careful of how you set your sample size. So the question is, why we became unpowered in this study? And the reason was, from our explanation, was that the incidence of mortality and nosocomial infection improved as we were doing this study. And it improved because of participating in a trial. And prior to this probiotic trial, we had done a CPAP trial, and prior to that, we had done a high-frequency trial. So all these trials improved the way people were doing that. We brought all these people who were doing things differently to do it the same and to look at it more objectively at the information, and they changed their protocol. So that decreased the mortality and the incidence of infection. Our rate, we had a predominance of gram-negatives, it inverted completely to gram-positives. And so all those things, when you're going to write these papers, you have to explain to people, because somebody needs that information so that they don't make the same mistakes. But if you don't give that information, if you don't disclose, and so people can't advance in what, you have to be very honest. And research is just like that. Or it gives you great results, or it doesn't give you great results, but you have to ask why. Let's see. So this is just a very quick example before I finish here. You have a study that they looked at in Colorado, 2004, comparing birth weights between babies in Ohio and Colorado. They took 1,000 babies and they did mean birth weights and compared them. And there are null hypotheses, which you should always start with that. There's no difference between treatment A and B, or between babies born in Ohio and babies born in Colorado. And the alternative hypothesis could be, during the year 2004, the birth weights of infants born in Ohio are different from those infants born in Colorado. It's not telling you who's going to have it. It's just telling you that it's different. And so, or you have to support the null hypothesis or reject it, and if you reject it, you're left with the alternative hypothesis. If you confirm the null hypothesis, then you reject that alternative. And then you have to establish what the alpha level is, the p-value. People put so much attention on the p-value, and the p-value it's not the magic. People reject studies by saying, oh, the p-value was not less than 0.05. And that's not, then there's no difference. That's the wrong assumption. For biostatisticians, p-value has been like the worst thing that could ever have happened to the biostatisticians, because it means that people don't try to understand what's happening with the data, but they just have something that tells them it's good or bad. And that's not the way you should look at these studies, because some studies, if you have a study that's underpowered, you might find that all the trends are going in to show towards efficacy, but you're underpowered to find that difference. Yes, that could be one of the reasons, one of the explanations. But if you just reject a study because the p-value didn't reach that, and again, even if we found a 40% difference in one study, a CPAP study, where we decreased BPD by 40%, but it was not statistically significant. And so you say, well, it doesn't help. That's wrong, because it depends. It has to be a much larger study, a better powered study, to look at that outcome. So don't reject them just because of the p-values. And so that's something that is important. And of course, the big error of not recognizing when there could be type 1 and type 2 errors, and why these studies, when you have small sample size, when we look at us just to do a simple study, randomized placebo-controlled trial of probiotics, you need 1,800 babies to do that. And then you find studies that have 150 babies in each group, and then they find a difference. You want to question that and say, well, or they had a very high incidence of necrotizing enterocolitis, which is very true. If their incidence was 40%, then you might be able to, with an intervention, decrease it by 50% and find a difference. But if your incidence of chronic lung disease or of infection or whatever is 6%, 3%, 2%, then of course your sample size has to be much, much larger to be able to find a difference. And so you can't exclude it because they have high numbers, low numbers. You have to look at what the incidence was. There's a study that in probiotics that came out of Israel that was very interesting, and they had a very, very high incidence, like 30-something% of necrotizing enterocolitis. So the question is, why did they have so much high incidence of necrotizing enterocolitis? But they did the probiotic study and they found a significant difference. In that population, it might have been possible with a small sample to do that. And so you can't say, oh, it was too small, the sample size, it's not significant. It can still be very important, but it depends on the outcomes. And so all these are things that, again, I'm just presenting to you as an overall, but I would like you now to, when we start giving our presentations here, to start using that framework, to start thinking that way, and to start asking questions. It's very, very important that you ask questions. If we're not asking the questions and not trying to go beyond what people are saying, it's very difficult for you to really have a good picture. You should feel very, very comfortable, and we hope that during the course of this symposium you do that with us. Thank you very much. So, anybody have any questions? Let's start with our questions. Yes?
What do you do when they stop the trial early because there's seemingly a result? How do you work out the fact that you start off with a hypothesis, you know what your difference is, and then in the group as it goes through, there seemingly is a thing, because we've had a lot of good trials stopped early because of an apparent effect, which then when people come to later, they say, did you really show that? That's...
Yes, and there are a couple of those trials that recently have been published. That's where you have to look at the short, if they're looking at short-term or long-term outcomes. And let me go back to that very important AZ trial, the vertical transmission. One of the concerns that we had with that trial was, you know, they at their interim analysis, they did show that there was a decrease that was significant in vertical transmission. But they had two components to that trial. And one was, of course, the use of the ACT prenatally. But they had, and what effects do they have on the infant that's exposed to the ACT? And then you're going to expose the baby for 6 weeks to AZT. And so when they stopped that trial, we said, why are they doing that? It's good to understand that you're decreasing vertical transmission, but there's a fundamental question that needs to be answered with respect to exposing babies to AZT, which is a more long-term question. I think it would have been wiser if they would have said, okay, we can't stop this component, but we need to continue with the long-term component of this trial. And people would have said, okay, that sounds very rational. And you don't, now that you found that there's efficacy and you demonstrate that, you don't want mothers not to be exposed to that intervention. But you can't stop this trial because it's important to see, we've never given ACT for 6 weeks to any baby, and does this have any long-term impacts? People are so weary about the ACT. I mean, if you talk about these trials and people get very upset of how frustrated they were with all these. And one of their opinions were, it's better to do a good trial and answer the question. Is it good? Is it bad? And you don't offer it outside the trial intervention. And why is that? Because once you say it's not good, pull that out, bring a new medication in, and keep the research moving until you find the right one. But with the way that it's happening with the lay community getting involved in this compassion care, many of those trials that are life and death trials, they don't get answered. And when you have studies that are stopped prematurely, you have to the question, well, did you answer all the questions that you needed to? And the majority of the time you find that no, that there's still very important questions that need to be answered. There's always a way to move forward, but sometimes people just stop these trials, and I think that that's not good. It's not, especially if they're not looking at long-term outcomes, which is the majority are not looking at long-term outcomes. Yes.
Concerning the short-term outcome and the long-term outcome, how long should be the long-term outcome? And it's not the same for the all disease, all disease, all indications, and the short-term outcome. How can you put the limit, saying this is the long-term outcome for me?
Okay. So I'm going to give you the word. What would you answer to that question? Because you're the perfect person to answer that question.
I think ultimately you want to look at school age, but we don't, our grant cycle is a 5-year cycle. So I think if you look historically, people have looked at, outcomes to hospital discharge, and then we figured out, oh wait, that's the wrong answer. We need to at least look until 2 years of age. And now we're finding out that 2 years of age doesn't necessarily correlate that well with school age function. So ultimately, I think we need to look at much longer term outcomes, and we're starting to do that, but I think many of our studies don't yet. So studies like what Kate will be talking about later today will be very important, looking at a cohort and then following them at 5-year intervals.
We had examples of studies that we would like to have long-term outcomes. When we started to do our Bailey scores, and we would look at 6 months. And then we found out that 6 months didn't make it then, so we said 1 year. And all our follow-up in developmental clinics started to change. We used to see like 3 months at 6 months, and then at 12 months. And then our instruments started to change also. Our tools found out that fine motor and other cognitive issues were not as well evaluated by these tools. And so we started to look at 18 months, and then 18 months went to 2 years. And now we find out that, yes, because all these are tools, and they have sensitivities and specificities and positive predictive values and negative predictive values. And because we don't put these to the test, we don't know really if they're appropriate tools. So let's say a trial looking at just caffeine and looking at the effects of caffeine. If you look at placebo versus no caffeine, and you look at a year, yes, you might not find the abnormalities from a developmental perspective. But who's to tell me that, and I think we agree at 5 years of age, you might not find a difference. People say that the farther you go away from the exposure, the less relationship you create between the intervention and the exposure. And that's our mind thought. But we're learning that with epigenetics and with many of what we're learning in science right now, that yes, definitely there are things that can happen in the newborn period that you only start to see much later on. So if you start, we would have loved that study to have gone to 5 years. But the reality again is that it's expensive. It's the most expensive thing to do follow-up to 5 years. And you would like to be able to see if at 5 years these children are having more difficulty cognitively than other children. So that basically, I don't know if it answers your question, but the idea is that we're looking longer and longer, and the people that are now dedicating time to look at those children when they're 15, there are studies that are followed to 15 years of age, are still finding these correlations. And so there's a lot of research in obesity right now that is starting from prenatal exposure and now looking them up to teen years. So that's going to be a trend. Other questions?
I have one question. When the land of alcohol treatment ranges works for so this is quite easy to understand when we speak about treatment, drugs, manipulation, and so on. But I feel that this also applies to diagnosis for intervention. In your slide, you mentioned for the some controversies about the SPO2 limits. I think that is a good example of how setting a different cutoff for defining what is normal and what is not normal can, in fact, influence the outcome of the disease. My feeling is that we know everything about the design of the study in order to protect the effect of drugs, but we are much less aware of the correct designing and correct reporting of the studies that should tell us how tests are performing also in our neonatal care. Do you have any idea on a critical area in which the diagnostic could be an important issue in daily practice in neonatology?
I think that they are. I'm going to start with one that was both obstetrical and OB, because we do have a lot of diagnostic tests with that. And it's a simple study. In the past, we used to use to evaluate fetal heart tool instrument that was called the Pinard. Do you remember this tool? The otoscope of Pinard. Yes, you remember it? Do you remember it? If you don't remember it, because we're too old. The Pinard was a very special stethoscope that the obstetricians used, wood. And that had never been, it was a diagnostic test that was never evaluated. And then in the 1970s, electronic fetal monitoring came into place. And so everybody threw away the Pinard stethoscope and started to use electronic fetal monitoring. And again, the same problem occurred. Nobody wanted to do a randomized control trial between these. But this was everybody. Everybody felt that something that was wood, that was with your ear, could not be as good as electronic fetal monitoring. So that went away without even any question. And only like 8 years after it was started, somebody did a randomized control trial comparing the Pinard to electronic fetal monitoring. And what they found out was that the rates of C-sections increased by 30% with electronic fetal monitoring. And then somebody said, well, what's the difference? How did you do this trial? And so there were questions about the methodology of the trial. So they repeated another trial in a higher risk population. And the protocol for hearing the fetal heart sounds was very strict protocol, where they had to do that, I think every 20 minutes they had to be hearing and documenting the fetal heart rate. And they let the electronic fetal monitoring run as it was. And again, they showed that you had 30% higher C-sections and a higher percentage of premature births in babies that were born without having any. We were delivering babies earlier than that. So there was the false positive rates were much higher with electronic fetal monitoring than with a Pinard stethoscope. And then they did meta-analysis on that, and they showed that that was true. It didn't change the way we did things because people have not gone back to that. Then they did to the ultrasound, and they looked at all the fetal monitoring with an ultrasound sheet. And they found out that that was even worse than the electronic fetal monitoring. That the false positive rates were like 55 and 60% because it was based on subjective, not objective, subjective evaluation of each individual clinician. And with respect to the electronic fetal monitoring, they did a study where they took a tracing and they distributed right among the group, just like you, and they were all experienced 25-year or more nurses or labor and delivery and physicians. And they all were asked to write down what their intervention would be for that. And it was incredible. We did that in the group, and there were like 5 different interpretations to what had to be done. And so diagnostic tests, yes, they have a sensitivity and a specificity, and you have to try to do studies to determine that, and if they're positive predictive value, negative predictive value. In neonatology, we use the CRP. How do you use the CRP, C-reactive protein?
Yes.
Okay, and so in Tennessee, Dr. Shelley Coronas, in his hospital, he did a lot of research in Memphis with this diagnostic tool, and he found out that the negative predictive value of the CRP is where the big value of it was. That when you looked at the sensitivity, it wasn't as good at detecting infections as it was at saying, oh, when there's no infection, truly there's no infection. And so we use that information with our students to tell them, yes, you need to, for every test that you're ordering, you should try to find out if there's objective information to tell you what is the sensitivity and the specificity of this. We tell them, don't do this test if you don't know what you're going to do with it. And that's the first question. I'm going to do this test. What are you going to use it for? What are you going to change in your management with that? Then don't use it. Don't order it, first of all. And second, if you're going to order it, do you know what the sensitivity, the specificity of this is? What is the predictive value? And so the CRP, for example, now helps us a lot to say when we're going to stop antibiotics. We had all these questions about doing 7 days, 10 days, 14 days, and so we're using this information now to say if it's negative probability that that child has an infection is very unlikely. We use the positive predictive value. The sensitivity helps us to associate it with other things that we're observing with the patient, and that, and so we understand the limitations of that. But you have to do that for every single intervention that you use, because it can change dramatically how you practice medicine. We don't really think like that, but we should be doing that. Does that answer the question?